Dear colleagues, today I am presenting the case of a patient who came to our attention during the 16th week of pregnancy with a suspected microcystic condition. In fact, upon ultrasound evaluation of the fetal skull, as you can see here from the ultrasound images, a cleft in the cranial vault in the occipital region became evident, which allowed us to raise the diagnostic suspicion of encephalocele. In particular, an encephalocele is a herniation of cranial contents through a defect in the fetal cranial vault. The herniated tissue may consist solely of meninges, resulting in a meningocele, or it may also include brain tissue, resulting in an encephalomeningocele. The incidence is 1 in 50,000 births, and depending on the location of the defect with herniation, there are several types. The occipital variant, which accounts for 75%, the parietal variant, 10%, the frontal variant, 10%, and a very rare variant that affects the facial region, such as the nasoethmoidal, temporal, or sphenoidal types. When examining the brain, we observe that the false choroid plexus's thalami and cerebral peduncles appear normal. However, this defect affecting the occipital region of the fetus becomes evident, as can be seen more clearly in these sagittal scans. The specific location of the defect necessitates a differential diagnosis with a cystic hygroma, which was the initial diagnostic suspicion. In this case, however, we observe the absence of the occipital bone plate, which is even more clearly seen in this scan obtained transvaginally. Within the herniation, there appears to be encephalic material, brain tissue, which defines the condition as an encephalocele. The causes of this condition can be traced to exogenous factors, such as folate deficiency, medications, radiation or chemical agents, as well as endogenous factors, such as syndromic conditions, chromosomal aberrations, or amniotic band syndrome. Therefore, this is a neural tube defect in which, unlike spina bifida where the posterior neuropore is involved, it is actually the anterior neuropore that is affected. Diagnosis is facilitated by the fact that there is a clear interruption of the cranial vault with herniation of tissue. In the case of small defects, what can assist and be helpful in diagnosis is the lemon-shaped appearance of the skull, the presence of mild or moderate hydrocephalus, and any association with facial anomalies such as hypertelorism or clefts, which occur in encephaloceles involving the facial region. However, upon close observation, we notice that all the structures of the posterior cranial fossa are actually not regularly visible, unlike the choroid plexus's thalami and cerebral peduncles. In this case, however, the cerebellar peduncles appear to be compressed and the cerebellum is not visible at all, nor is the cisterna magna. What is clearly visible is this large defect with a schisis measuring approximately 18 by 10 millimeters overall. In these cases, the differential diagnosis should be made with nuchal edema, specifically the cystic hygroma we mentioned, cephalohematoma, which, however, is purely a birth trauma, and occipital hemangioma, which, on the other hand, makes the presence of vascular tissue evident even on Doppler. The prognosis essentially depends on whether or not there is brain tissue within the herniation, because in the case of encephalocele, mortality is high. It can reach up to 45%. And of course, it also depends on the extent of the schisis itself and any possible association with other anomalies. Syndromic conditions most frequently associated with this condition include amniotic band syndrome, occurring in 1 out of 10,000 cases, Meckel-Gruber syndrome, which is an autosomal recessive disorder characterized by a typical triad, namely a brain malformation associated with encephalocele, together with polycystic kidneys and polydactyly, as well as various types of bone dysplasias such as Silverman-Enmacher syndrome or conditions like phocomelia. This is why it is essential to conduct an in-depth anatomical study of the central nervous system. In this case, we can see how the choroid plexuses were evaluated and how hydrocephalus, a condition that is often associated with this disorder, was ruled out. A thorough study of the fetal spine was performed and it was found to be normal. Naturally, an in-depth anatomical study of the kidneys was also carried out, and they were found to be normal in both size and echo structure. In this way, polycystic kidney disease was ruled out. A thorough morphological and biometric study of the long bones was performed, both of the lower limbs, as we can see in this case, which appeared normal, and of the upper limbs. In particular, special attention was given to the study of the hands, also in order to rule out conditions such as polydactyly, which we have seen can sometimes be associated with syndromic conditions linked to encephalocele. In this case, however, this condition was excluded as the hands showed normal morphology on both the right and left sides. The rest of the fetal anatomy included in the biometric study of the fetus also appeared normal. Therefore, in a case like this, it is obviously recommended to conduct a study of the fetal karyotype in order to rule out syndromic conditions or chromosomal abnormalities. A thorough ultrasound examination, as was methodically performed during this study, with particular attention to the kidneys, skeleton, and long bones. A fetal echocardiogram should be recommended to the patient. In this case, the fetal heart was found to be completely normal. A pediatric neurosurgical consultation in order to guide both the expected outcome and any potential surgical approach to the condition, a neonatology consultation, and of course, monthly ultrasound follow ups to monitor the defect, any association with changes in amniotic fluid, or the onset of conditions such as, for example, hydrocephalus, and obviously, delivery is recommended at a tertiary care center. Thank you for your attention.